Well, hello, and welcome to the Multiple Sclerosis Association of America's live webinar, What Now? A Post-Election Update. I'm Kyle Pinion, Senior Director of Education, Healthcare Relations, and Advocacy.
And I'm Rebecca King, Director of Education and Healthcare Relations. And as your advocacy team at MSAA, we're so excited to have you join us for what's going to be a fascinating and timely presentation on the new political landscape in 2021. And also, just how it will impact not only healthcare policy, but those living with MS.
That's right, Rebecca, and we're so honored to be joined tonight by our good friend Chris Sloan, who is an associate principal at Avalere and an all-around brilliant guy, who's going to help guide us through these upcoming changes. Rebecca and I will be acting as co-hosts tonight, so we're going to do something a little different. And during the course of the program, we will likely ask Chris a few questions and maybe even address your questions live as they come in.
So exciting. But before we begin, it's important that we remind you that MSAA is a national nonprofit organization dedicated to improving lives today for the MS community. In fact, this year marks MSAA's 50th anniversary as an MS advocacy organization. And some of our free services, many free services, include a national helpline, equipment and cooling products, MRI funding, an online community, webinars, and the list goes on and on.
Also, hey, don't forget to visit our website to experience our new COVID-19 and MS Pathfinder tool, which provides ongoing updates and resources on the coronavirus, a topic we'll discuss tonight, as it turns out. Also, please know MSAA has expanded our helpline hours to 8 p.m. Eastern between Mondays and Thursdays. To learn more about all the ways MSAA improves lives today, please visit mymsaa.org or call 1-800-532-7667.
And one last item, please know that tonight's program will be archived to our website very soon. And for a Q&A session, please type all of your questions into the chat box and we'll address them at the end of the presentation. But also, if you're having any technical issues, I promise you won't be the only one out there. Please type those concerns into the chat box as well, as our friendly Zoom staffer, Tom, will be more than happy to help.
With that said, we're so excited to once again introduce tonight's presenter, Chris Sloan. Rebecca, please do the honors.
Absolutely. Chris advises a number of clients, including pharmaceutical manufacturers, health plans, providers, and patient groups on key policy issues facing the healthcare industry. His particular area of expertise actually includes prescription drug pricing, economic and population impacts of policy, the Affordable Care Act, generic drugs, and biosimilars. Additionally, Chris is a recognized expert in the healthcare policy issues facing people living with HIV/AIDS and multiple sclerosis. His economic analysis of key policy proposals and issues, including drug pricing and the repeal and replace efforts around the ACA, have been featured in a wide range of publications, including the Wall Street Journal, the New York Times, the Washington Post, Politico, Axios, and Vox. Chris's work has also been cited by policymakers on the Senate floor and by the Congressional Budget Office. So without further ado, Chris, take it away.
Great. Thank you, Rebecca. Thank you, Kyle. Appreciate you guys having me here today and being back at one of these webinars. I always enjoy it, and I always enjoy the questions. So really just appreciate the opportunity to talk to everyone today. And this is a fun topic that we get to discuss. Really, we've had an election. We get to look ahead to a new administration. There's all sorts of interesting things going on right now that we are facing in the healthcare system today. And so looking ahead to 2021 and what this election means for people living with MS and also just generally for the healthcare system at large, it should be a good discussion. So let's just go ahead and dive in. So Obviously, if you haven't been paying attention to the news recently, this will come as a shock. But if you've been paying attention, this should be pretty straightforward. But the Democrats have won the presidency with President Joe Biden. They've also maintained control of the House heading into the next legislative session. And the Senate is still up for grabs, which is sort of a unique situation to find oneself in a month after the election. But given the way that the elections in Georgia work, we have 2 Georgia Senate seats up for election here in early January. So we're going to have to wait until January to find out which party controls the Senate. So that leaves a decent amount of opportunities and variances as we look ahead into 2021 and beyond as to what healthcare policy is going to look like. It's very different if the Republicans maintain control of the Senate versus the Democrats maintaining or gaining control of the Senate. And so unlike many years in December, when we can sort of have some confidence in what is going to happen politically in the next year, that's still very much in play. And so we'll talk through tonight some of the differences of what could happen if Republicans maintain control or Democrats take the Senate. But unlike, I think, in prior years, there's just still a little bit of uncertainty heading into 2021 and the next legislative session.
So, Chris, could you provide an example scenario just on how a potentially split Congress, like one of the scenarios you present there, how they could potentially impact a bill? Like Rebecca and I were talking about making up a bill here. So let's say all stop signs must now be the color blue. That's going to be the bill that we're going for. How would that be impacted by the split Congress?
Yeah, it's a great question. I mean, fundamentally, right, it is easier to move legislation and policy priorities when one party controls all branches of government, right? That's very straightforward. And as we'll talk about on the next slide, if the Democrats sweep the Senate, and I can actually jump here to the next slide. If Democrats win both the races in Georgia, it will be a 50-50 split in the Senate. And what that means is that Senator Kamala Harris, who will be Vice President Harris come January 2021, becomes the tiebreak. And so for all intents and purposes, Democrats will control the Senate, even if it is a 50-50 split and they sweep the sweep the 2 races in Georgia. So that matters, right? Because what happens when the Democrats control the presidency, control the House, and control the Senate is they get to set the agenda. Whoever runs any body of government, either a House of Congress or the presidency, gets to set the agenda. If you run one of the houses of Congress, you get to decide what bills come up for votes, right? You can sort of simply delay or avoid passing types of legislation you don't like because you don't bring it to the floor for a vote. You appoint the committee chairs, which are very powerful, particularly in the Senate. Those committee chairs get to debate piece of legislation. That's where legislation is typically drafted, is within committees in Congress. And if you have one party controlling all of that, you can get a lot more done. You can move things faster. You can work with your colleagues who are in the same party in the House and the Senate and work together to try and pass legislation. And you know that the president will sign it because, for the most part, your priorities are aligned with his. So unitary control of government is a really big deal. It's not a be-all, end-all, and we'll talk about that in a little bit of some of the limitations to that. But one fun fact I was looking up before this presentation, so we have these 2 races that are still up in Georgia. This happens more than you think, that there are 2 Senate races in a given year. It's almost always a case of a special election for one seat and then a normal election for the other, which is what's happening here in Georgia. But the last time races were split, meaning one party won one seat and the other party won the other in when there are 2 Senate races up at the same time, was 1966. Since then, the same party has won both seats in any year where both Senate seats are up for election, which is astounding. I mean, that's, over 50 years of, and, this doesn't happen every year, but it does happen more than you would think, of one party sweeping the Senate races. So this is going to come down to the wire. Polling is very close, but this matters a lot because it really is a big part of what could allow President Biden to implement his agenda, particularly his healthcare agenda, or conversely, if Republicans hang on and control the Senate, allow them to stop the agenda or, moderate it substantially by extracting concessions that the Republican Party may want out of any healthcare agenda that moves at least for the next 2 years until we get the next House elections and Senate elections.
So, Chris, one thought that continues to bounce around in my head, and that's a really interesting factoid you shared, by the way. Very, very, very interesting. Since the Senate margin will be relatively close either way, is there a possibility that the new administration could deal their way into bipartisanship on certain measures? I mean, they may have to, but I'm really curious, particularly when it comes to healthcare related strengthening of any kind. Is there potentially some flexibility there on the other side of the aisle where some good wheeling and dealing could get something done?
Yeah, it's a great question, Kyle. I mean, I think obviously situations where control of any branch of government is very close or sort of very evenly split creates a lot of opportunity for bipartisanship, right? You sort of inherently have to provide concessions to get legislation passed, because otherwise nothing's going to move. And it is really important to note here that, this slide shows, we haven't even talked about the House of Representatives, but this slide shows Democrats in blue, Republicans in red. There is a spectrum. There are very different senators on both sides, from very far left on the Democratic side to some of the more moderate senators like Senator Manchin from West Virginia. And then you've got the same thing on the Republican side. You have very far right or more far right Republicans. And then you've got, more moderate Republicans like Susan Collins of Maine. Even within the caucuses, you have to do a little wheeling and dealing to get things done, because you have to convince the more moderate members or the more conservative or liberal members of your caucus to help move legislation through. And so, Kyle, to your point, I think close elections lead to more bipartisan legislation and bills, but it is not a guarantee. And particularly in areas where there's a lot of politicization, which unfortunately that is healthcare, it also creates a lot of gridlock. And so I think we can sit back and say, looking ahead to the President-elect Biden's first term, regardless of what happens with the Georgia Senate races, we're unlikely to move anything that's really ideological, right? Something that's really big in the base of either party. Anything that moves is likely going to have some bipartisan support, or at least some veneer of a centrist proposal, in order to not only get, some people walking across the aisle to support any piece of legislation from the other party, but also to get everyone in your party together, because there's not room for error, right? If you lose one more liberal Republican or you lose one more liberal Democrat from your caucus, you're not going to pass it. And so it really, I think, narrows the list of things that can be done, and the things that can be done become much more bipartisan and much more centrist, for lack of a better word. And so that leads us to, okay, so what do we do, right? If it's going to be tricky to move things through legislation, then what are the other opportunities to move things through Congress? And that's where we start to get into what kind of regulations and what can President Biden do on his own without the use of Congress, without sort of this close, very close margins in both the House and the Senate, and get things done. So on regulation, the administration has a lot of flexibility through regulatory actions. They can take a lot of actions around shoring up the Affordable Care Act, not making major changes, not increasing money or anything like that could help with affordability, but pulling back a lot of things that the Trump administration has done that maybe have loosened benefit design requirements, made it easier to buy less generous plans, things like that. A Biden administration can reverse those things. They can also use what's called CMMI, which is here on the slide, which is the Center for Medicare and Medicaid Innovation, CMMI. And this entity is given a lot of authority to change things in Medicare and somewhat to a less extent in Medicaid. And so we've seen the Trump administration, during a time of political gridlock, use this entity to try and advance some drug pricing proposals, to do drug importation or try to do drug importation from Canada, things that would not make it through Congress, but could be done, now again, only for the Medicare program, but there's a lot of flexibility on the kinds of things you can do. The other thing, is what are some things within legislation that they can do, and what are some, we'll call them tricky workarounds in Congress. And this is where it gets really fascinating, because we start to get into some of the minutia of the Senate rules. So in the House, if you got a majority, you got a majority, right? You can pass what you want. The other side can't stop it. If you've got more people than them, in this case, there's more Democrats than Republicans, Democrats can pass whatever they want. That's why when you're watching the news, you tend to see a lot of stuff about the House passed X that then just disappears, right? You don't ever hear about it because the Senate doesn't ever do anything with it. It's because all you need is a majority. You can move things through. In the Senate, there's something called, basically a filibuster-proof majority. And in this case, in order to take a bill to a vote in the Senate, you have to get 60 votes, right? Which is a lot more than half, right? Like that's a super majority. That's a ton of people. That's, way more than either side will have coming out of this election. And if you don't have 60 votes who vote to end debate and take the bill to the floor and then have a vote on the bill, like the merits of the bill, whether to pass it or not, the bill effectively gets filibustered, right? It's just left on the floor. It never gets taken up for a vote. And so one of the challenges in the Senate is getting to that point and getting a bill passed through the Senate oftentimes requires many more votes than a simple majority, and therefore a lot less happens through the Senate. There is one way around that. This is called reconciliation. And in the case of reconciliation, you only need 50 votes, or a majority of votes, right? 50 plus 1. There are limits on that, which I can go into in a minute if folks are interested, but there's sort of limitations on what you can use a reconciliation process for, but it's a way to move things through and get around that 60 vote threshold for taking a bill to the floor to vote. But there's only so much you can do with that process. But those are really the ways to move things, right? We've got regulation and the Biden administration doing things through regulation, regulatory entities. And then we've got, particularly and only if the Democrats take control of the Senate, this one vehicle that they can use to move some things around that sort of 60 vote threshold that currently is a barrier to a lot of legislation moving forward, getting around that, what's called the filibuster, and running something through this reconciliation package.
Great. So Chris, do you mind, can we just back up just a second, especially for those on the call who maybe are not as familiar with advocacy? Can you go into more depth about filibuster and the reconciliation process and like, why does that even matter? Why should we even care about it?
Yeah, absolutely. And I would love to, Rebecca. I love going into the details on these things. So sorry, folks, if you were like, oh, I don't want to hear about arcane Senate procedures. So the filibuster, I think for those of you who remember in school, like when we think of filibuster for the most part, we think of someone standing on the floor of Congress talking, right? And not stopping talking and delaying things because they won't get off the floor, and they're filibustering, right? Which is basically just talking as long as they can. There was a very memorable one years ago by Ted Cruz, who spoke for like 18 hours on the Senate floor. There's been other high profile ones. That's what we tend to think about from a filibuster. But this is a little different. So the rules within the Senate, when we say filibuster in relating to the Senate, really what we mean is that once a bill makes it out of a committee and is getting ready to be voted on the Senate floor, Congress holds a vote, not on the bill, but whether to vote on the bill, right? So 2 votes. 1, should we go vote on this bill? Yes or no. And then if you say yes, then the bill goes to the floor and then you actually vote on the bill. To vote on a bill, that second step, you just need a majority. But to vote that you want to vote on the bill, hopefully folks are still following, you need the 60 votes. That's the filibuster, right? You can sort of filibuster by denying 60 votes to move the bill, end debate on the bill, and move it to the floor to vote on it. So that's what we think. That's what we talk about when we talk about the filibuster. And that is why lots of things don't happen in the Senate, right? Because rarely does any party have 60 votes. And so almost inherently, you have to have some compromise, some bipartisan support, even if they don't vote for it, to at least let you vote on a bill, right? To sort of clear that filibuster threshold. And since in this case, max will have 52 Republicans, 48 Democrats, or it could be 50-50 with Democrats in control, it's unlikely they're going to get that many votes on many sort of controversial issues. So that brings us to reconciliation, because at some point the Senate said, well, this is making it very hard to do things, and there are some things we have to do, right? We're okay being slower than the House, but there are things we actually have to do to make this work. And that's where reconciliation came in. So reconciliation, again, it's a procedure in the Senate because the House is very easy. You just pass the thing. Reconciliation is explicitly designed for like budget related items. So things that impact spending. They have to have a direct budgetary impact. You can use it once per year. It's a one-time thing per year. And the Senate can pass, it's called a reconciliation package, with just a majority. And you can get around that 60 vote filibuster majority and do it with a reconciliation package. So this is very technical, and it's also sort of hard to do in practice, right? Because you still need to get a majority of your caucus, 50 plus one at least, to vote for it. And then everything you do in that package that you can only use once per year has to be budget related. So it doesn't let you change a lot of things, like a lot of rules or regulations or things that don't have a direct spending impact. It tends to be pretty narrowly defined, and it was designed to let them pass a budget, right? That was sort of the idea. But you can pass it in plenty of other situations and pass many things through in similar situations, but it's sort of a one-time deal. So that's what a filibuster is. That's what reconciliation is. For those of you in 2004, this is just a fun fact for you, not related to this presentation at all. But if you remember, there was a lot of controversy around Senator John Kerry when he was running for president, where he said something to the effect of, I actually voted for the bill before I voted against it. It was something to do with defense spending. What he was talking about, maybe I'm the only one who remembers that, but what he was talking about was that he voted for ending debate and taking the bill to the floor to be voted on, and then he voted against it. So it was this situation, right? He was voting to end debate, which required a 60 vote filibuster, and then our 60 vote threshold. And then when it went to the floor of the Senate, he voted against the bill. That obviously, it took me 5 minutes to describe this. So he obviously wasn't going to be able to do that in the middle of a political campaign, but that's where that famous gaffe comes from, for those of you who remember.
For the record, Chris, I remember it.
Okay, oh, good. I was worried as I was saying this, I was thinking maybe no one remembers and this will be a dumb anecdote. So thank you, Kyle. Okay, so let's look at the kind of stuff that could be done, to the earlier question, through bipartisan means, right? What are the kind of things that could end up in legislation, right, here on the left in orange, or through, as I was talking about, what the Biden administration could do without asking anyone else, doing it through regulation or CMMI, which I talked about earlier. So on the legislative side, there are some things largely sort of drug pricing focused that could get some bipartisan support. The biggest one, and I think the one that's probably most likely to move, is Medicare Part D redesign. So for a long time, folks in both parties have looked at Medicare Part D and said, this is a program that needs updating, right? There's no out-of-pocket cap in spending. People who have high spend on drugs just keep spending and spending and spending without any sort of cap. And that needs to be fixed. And we got pretty close to a bipartisan deal end of last year that looked like it was going to happen this year, but then COVID happened, and that sort of sucked up the oxygen in Congress, and everyone was focused on that. But this is the kind of thing that could move, that could be full stop good for patients, good for people living with MS who are in Medicare Part D, because it could put a cap on your spend, right? You would say, depending on the bill, there's some that are for $2,000 maximum per year. There's another one that is for $3,100. But that is much better than some folks face today, where they just have, spend all year. Your cost sharing goes down every year, but there's no cap. So that's sort of a good bipartisan thing that could move. There's some other stuff related to inflation penalties on drug pricing trends, surprise medical bills, which could actually pass this month. There was a bipartisan deal just struck this week. But a lot of things focused on sort of specific issues that have bipartisan support for fixing, largely focused on drugs, right? That's where there's a lot of bipartisan focus. One thing you'll note is not on this list, and I'll talk about it here in a second, is coverage, right? Health insurance coverage, not something that has a lot of bipartisan agreement. Then on the regulation and CMMI side, it's sort of the same stuff, right? Looking at a lot of drug pricing, looking at a lot of demonstrations to try and reduce the cost of prescription drugs coming through the Medicare program in particular, trying to make good on some of Biden's promises to evaluate the price of drugs, to try and create a system that assigns value to drugs when they're launched and says this is what the price should be, those kind of things. And then also, and we'll talk about this in a little bit, rescinding a lot of the changes that the Trump administration made around the Affordable Care Act that maybe made coverage less accessible to people, and trying to sort of go back to Obama era support for the Affordable Care Act, which the Trump administration has very much been on the other side of throughout this process.
So, Chris, among this entire sort of litany of potential reform efforts, where would you see the greatest potential impact for the MS community in this entire slate of possibilities?
Yeah, I'd point you to the corners. So I guess this is upper left, if you're looking at your screen, Part D redesign. That, I think, has a material impact on patients. It would mean lower cost sharing. Many patients with MS spend a lot on prescription drugs. I don't need to tell people on this call about that. Putting an out-of-pocket cap in Medicare Part D would have a real tangible benefit in helping folks afford their medications, right? And sort of putting a limit on how much they spend in any given year. And then the bottom right here. So the Biden administration coming in, shoring up the ACA, improving coverage, trying to find ways, not big sweeping changes, right? There's only so much they can do through regulation, but things to try and make it a little more affordable, make coverage a little more accessible, improve things like networks so you can see more doctors, things like that. Those are the kind of things that I think are most likely, and also most likely to benefit patients with MS and the MS community. So this is sort of just doubling down on that last point here. And so Kyle, that question set this up very nicely. But we have had 4 years of a Trump administration that has been skeptical of the Affordable Care Act. Right? I think that's safe to say. We'll talk about the court case here in a second. But the Trump administration has done a variety of things that have been really geared toward one specific goal, which is, try to think of a good way to say this, making coverage more affordable for healthier individuals, right? That's probably the best way to think of sort of the Trump administration's philosophy around the Affordable Care Act, is that they've been working to make coverage more affordable for healthier individuals. And so that has been things like allowing healthy people to go and purchase short-term plans, right? Plans that maybe don't cover drugs or don't cover hospitalizations. They're much cheaper because they don't cover those things. Maybe they medically underwrite the patients. Those kind of things, giving those kind of options, giving states more options, states to do things like, say, get rid of healthcare.gov, which is something that Georgia just got approval for, and instead let private vendors administer coverage in the state. So instead of going to healthcare.gov to pick your plan every year, you go to a private vendor like eHealth or getcover.com, and just sort of picking. These are not the actual vendors, but just sort of picking sort of web broker type portals. Adding work requirements to Medicaid, right? If you're an adult getting Medicaid, requiring you to work or show that you're pursuing work in order to get Medicaid and health insurance coverage in that state. Those are the kind of things that the Biden administration is going to get rid of, right? They're going to just, as soon as they get a regulation in there, which will probably be sometime later in 2021, they're going to repeal all of those things. And Biden is going to follow a tack that's much more focused on what the Obama administration was doing in 2016, and focusing on improving benefits, adding sort of guardrails for health plans to sort of prevent them from offering these short-term limited duration plans, for slowing or trying to slow the growth of the maximum out of pocket in these plans to make them more affordable, have patients spend less in cost sharing, improve formularies, improve networks, all of those things geared at a little more controls over the type of coverage being offered and try to make it more generous. Now, the trade-off is that makes it more expensive, particularly if you're healthier and don't really need your coverage. But the flip side of that is it makes it better for people who actually need coverage, right? And need to use their health insurance. And that is going to be sort of a big principle and a big change from the Trump administration to the Biden administration. One thing you'll note about this isn't sweeping, right? This isn't Medicare for all. This isn't a Medicare buy-in. This isn't a public option. Some of those terms you may have heard during the campaign, and all parts of the Biden platform. Because of how close the Senate is, and frankly, the House is close too, even if Democrats take control of the Senate, it's still going to be really hard to get sweeping coverage changes through, And that's kind of a hard thing to say for folks who are paying attention to this campaign. And so much of it was about the healthcare proposals of the Biden campaign. And even if you go back into the Democratic primary, how much of it was about Medicare for all and those kind of topics. But the way the election shook out, even without knowing what happened in Georgia, it is unlikely we get anything close to that in terms of actual legislation. And that means most of the changes will be done through regulation, like these ones that I've listed here. Maybe they try to get something bipartisan through Congress, but for those of you who follow politics, it's really hard to get Republicans, Democrats to agree on healthcare. It's hard to get Democrats to agree, just generally, sort of the breadth of policy positions within that caucus. So this is, I think, the way the election shook out. One of the biggest changes that we at Avalere, who are advising clients all the time, started having to tell clients to say, hey, don't expect the big changes legislatively, right? We're going to focus on regulation. We're going to focus on those kind of things that are of benefit to patients and those changes there, but we're not expecting sort of a wholesale change of where Americans get their insurance or really what that insurance looks like heading into the next year because of the way the congressional elections have shook out and likely will continue to shake out after the Georgia runoffs. So I've been talking a lot about the Affordable Care Act and avoiding the elephant in the room, which is the Supreme Court case, right? So many of you have been paying attention to this. For background, for those of you who have been happily not paying attention to this, the Supreme Court has taken up a case. It's called California v. Texas. This case is challenging the constitutionality of the Affordable Care Act, right? Or Obamacare, as it's often referred to. Many of you are thinking, didn't we just do this? Haven't we done this multiple times? And the answer is yes. This is at least, I think, the third case that has gotten up to the Supreme Court about the Affordable Care Act. But what's interesting is they're arguing the same thing that was argued in the first one in 2012 that ended up upholding the case. At a very high level, not to bore folks here, but just sort of go through at a very high level, what the case is about is the individual mandate. The Affordable Care Act included a mandate that said you have to buy insurance. If you don't, then you have to pay a penalty. In 2012, there was a lawsuit that said that's unconstitutional. The Supreme Court looked at that and said, it is constitutional because it's basically a tax, right? If you're paying a penalty because you didn't have health insurance, that's the same as a tax. The government has the authority to tax. It upheld the Affordable Care Act. Flash forward to end of 2017, Congress, at the end of the year, got rid of the penalty, not the mandate. There's still a mandate that says you have to buy health insurance in the United States. They just got rid of any penalty. Basically, the penalty is $0. So if you don't buy insurance, doesn't matter. Your penalty is $0. When that happened, Texas and a few other states looked at that and said, well, the reason the Affordable Care Act was constitutional in 2012 was because the mandate was a tax. Now it's not a tax. Now it's just a mandate. Therefore, we're going to challenge the law again and try to strike down the law. The Trump administration agreed and joined with Texas. That led to California and sort of more liberal states defending the Affordable Care Act, and now it's moved to the Supreme Court. There were oral arguments, so the arguments are done. The case has already been held in November. It was on November 10th, and now we're just sitting here waiting for the decision, which we're probably not going to get until June of 2021. So we're still likely 6 months away. That's the background. I think the main thing I want to leave you with is this is very, 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 I'm going to say it again, very unlikely to overturn any meaningful part of the Affordable Care Act. We listened to the oral arguments, other commentators, Supreme Court blogs, listened to the oral arguments. Everyone left thinking there's no way they're striking down any of the parts we care about of the Affordable Care Act, right? We have 4 scenarios here on this slide. Scenario 1, they uphold the whole thing. Scenario 2, they just strike down the individual mandate and leave the rest of the bill. Basically, it's called severing that piece from the rest of the law. Scenario 3 and scenario 4, that's where they strike down more and more of the law, pieces that people actually rely on for health insurance. Scenario 1 and 2, for us, for the MS community, exactly the same. No difference at all. There's no impact on coverage if scenario 1 or scenario 2 happens because it doesn't affect any of the pieces that lead to people getting insurance in the United States. That is far and away the most likely scenario. I think from Avalere's perspective, from other folks' perspective, there's a very, very minuscule chance that anything else besides that happens, and that at the end of the day, we either get scenario 1 or scenario 2 on this slide. Now, that doesn't mean scenario 3 and scenario 4 can't happen. Those have been crazy things that happened at the Supreme Court before. But I don't think anyone on this webinar should sort of be worrying about this for the next 6 months as if it's a likely outcome. It's always a chance, always important to be prepared. But at the moment, based on everything that we know and everything that we've seen in the court cases, it seems unlikely that anything will change that will hurt the Affordable Care Act when we see the Supreme Court decision in June.
So just in case, though, were the ACA to be struck down, where does that leave people who are on marketplace-based plans during the current coverage year? And more broadly, what would be the temperature for a new solution for people with pre-existing conditions?
Yeah, Rebecca, that's a really great question. So this is where this gets a little more depressing, right? Because one of the major things, and for folks who are on marketplace coverage today, you know this, one of the reasons that coverage is affordable is because of the subsidies. So the money coming from the federal government to subsidize that coverage. And if that goes away, a lot of people won't be able to afford their coverage. Many states have put things like protections for pre-existing conditions, require health plans to cover drugs, those kind of things into their own laws, not just the federal law here, but also their own laws. And so from that perspective, you're still going to have access to insurance, still have access to drugs in many cases if you live in one of those states. But if you're getting funding to help you afford your coverage, that would go away. And many people will be unable to afford their coverage and going to have to become uninsured. And then there's plenty of people who live in states that have not done this, right? You know, many of these states also haven't expanded Medicaid. You're thinking about Texas, you're thinking about Florida, where folks will just lose coverage, right? It just go away. And then what we have to rely on is Congress, which again is a very split Congress, coming together with some sort of solution and some sort of stopgap. I think the most likely outcome in that situation is there is some sort of time given by the Supreme Court for Congress to figure it out, or Congress passes something with a sort of end date that says we are going to maintain the rest of the ACA except the mandate which was struck down for 6 months while we figure out what to do and try to come up with a bipartisan compromise. And that kind of keeps getting kicked down the road until they come up with something. But there's no guarantee that what they come up with in a split Congress is better. In fact, probably is going to be worse than the ACA. So, if this happens, I would say there are not sufficient guardrails in place to automatically catch people who may suddenly find themselves without coverage. And that's a real concern, right? And I think we're unlikely to see anyone put those guardrails in place over the next 6 months. And then we sort of just have to hope that A, it isn't struck down, but also B, if it is, that there's enough time given for Congress to figure out a replacement. Sorry, I've been somewhat optimistic on the call today, or the webinar today, and then Rebecca asked that question. Now it's just like, whoop. But let's talk to something more. Talk about something more exciting: COVID. So moving a little bit away. So we kind of have 3 parts of the presentation, right? One is the election outcomes and implications for that. 2 is coverage, right? Affordable Care Act and coverage, and what a Biden administration may do. Now let's talk about COVID. This is the other big healthcare topic currently out there. We've had this week the first immunizations within the US, which is fantastic. And we're expecting a pretty strong ramp up of vaccines for the Pfizer vaccine and the Moderna vaccine, which will be rolling out soon. And then obviously some of the other vaccines the US has pre-purchased, like the AstraZeneca vaccine and others, throughout sort of Q1 and Q2 of next year. One question I get a lot, and we're going to talk about here on 2 slides, is sort of what does the trajectory look like? Like, when do I get it, right? When do, in this case, patients with other sort of medical conditions, when are they more likely to get the vaccine? When do I get in line? How do I get it? Things like that. And so I have 2 slides here showing recommendations. This is from the National Academies of Sciences, Engineering, and Medicine. The next slide is from the Advisory Committee on Immunization Practices, which is known as ACIP. both of which would have put out recommendations for how to do this and for whom the vaccine should go to first. And this is just instructive. I think before I go into these phases, I want to be very clear. These are recommendations from specific entities. This is not official US policy. There are recommendations out there, but the Trump administration is leaving it up to states to decide how to allocate vaccines. So when a person gets it, same person, different states, may vary depending on what state they're in, because states are being given a lot of the leeway for distributing the vaccine. Likely, when Biden comes in and his administration has been doing a lot of prep work here, sort of his administration in waiting has been doing a lot of prep work here, he will likely start pushing of more guidance federally, but even still, even if they take a little more active role than the current administration does, this is still going to be run a lot by states. So I think that's just an important caveat here. But under the National Academies of Sciences, Engineering, and Medicine, there's a few phases, right? And then we have some sort of general estimates of the size of populations within each phase. So phase one, healthcare workers, that's what you've been seeing in the news so far. They're getting it first responders. You're also, individuals with comorbid or underlying conditions that puts them significantly at higher risk. Those individuals tend to often be in nursing homes and assisted living communities, tend to have respiratory ailments that make it more likely for them to experience severe complications with COVID-19. It also, I think, is important to note, is places where people can be identified, right? It's easy to identify a nursing home. You say, oh, that's the nursing home, I'm going to give doses there. So, you can sort of quickly immunize folks who are at high risk, folks that have been sort of most likely to die of COVID-19. You get through phase one, phase 1A and 1B, you get to phase two. This is when you start to get to frontline workers, essential workers, as you often hear them called. You tend to get people of a variety of ages, so not just older adults with comorbid or underlying conditions that put them at a higher risk. This is folks, other folks who work or live in crowded areas that are more likely to sort of have respiratory spread of COVID-19. And then obviously older individuals who are not included in phase one. This is probably within this basket of recommendations. This is probably where patients with MS would be in this phase two. And then we've got phase three, which tends to be younger adults, folks who are just not as at risk. This is where, folks like me, frankly, working at home are likely to fall either here or in phase four, who just are sort of at lower risk of catching the disease or having other complications from it. So that is the National Academies of Sciences, Engineering, and Medicine. Kyle.
Yeah, so I think the overriding question for a lot of our attendees here tonight is just where MS would fit into these phases. I'd like to guess it's phase two, but I'd be interested in getting some affirmation on that. And also, and I know you're not an immunologist, Chris, so I may be pitching this to the wrong person, I'm sorry, but has there been any documented risk anywhere of these upcoming vaccines having any effect on people using MS-DMTs?
Yeah, that's both of them are great questions. I think yes. I mean, phase two is where it appears patients with MS would fall within this hierarchy. If, again, to my caveat at the beginning, if this is where folks fall, or this is sort of the process that states follow. I think also one really important thing here is initially, states are being given truckloads of vaccines, right? It's like, here you go. Here's your vaccines, take this to your hospitals, take this to your frontline workers, take this to the nursing homes. One thing you'll notice about that is that's not them walking into CVS and getting immunized, or going into their doctor's office and getting immunized, or showing that they have insurance from XYZ health insurance company and them paying for it and getting you the vaccine. So I think what will happen is you'll have a lot of phase one, which is sort of the government distribution of vaccines to state governments who then distribute them more broadly. When you get to phase two, really somewhere between phase one and phase two, at some point that changes, right? At some point, vaccines enter the normal distribution system for vaccines, like the same as you go to CVS and you get a flu shot, or you go to your physician and get some other vaccine. And that is where I think folks will end up in getting it. That's sort of how you're going to get access to, is when that changeover happens. And that's when folks will start to be prioritized by their physicians. And I think, as we think about people with MS, that's when I think you'll end up getting access to the vaccines. And again, that will vary by state. Kyle, for your second question, so I am very much not an immunologist. And so that's a question I would love to answer. And I have a thought in my head, but I think, having not gone through the trials, I don't want to say whether they have been tried in patients on some of these therapies and whether there are any reactions. I think one thing just to note is that they are keeping a close watch on this. I think, there have been, there's been some reporting on side effects that have been relatively mild. There's been, this week we saw some recommendations around individuals who've had adverse reactions to vaccines before. But as this moves on, I think the expectation is we will continue to get more and more data. Physicians will start to know and have some more information about how it affects their particular patients and how they're going to get access to it. And so I will say, having not looked at the trial data, have not looked at the underlying populations that they've trialed this on, trust your physicians, right? They're going to be paying attention to this. They're going to know. They're going to be asking these questions. And I think you can trust that there's going to be enough information out there for them to make informed decisions and vaccinate when appropriate and when they get access to supply. And that's going to be the best way to do this, because they're going to be following this very closely.
And Chris, just to follow on, because we're getting a lot of questions about the vaccine, as you can imagine.
Oh, yeah.
But one of the questions that was asked was, in that phase 2 period, how will people best be able to safely access the vaccine? Is this a question of being able to go to your local Walgreens or CVS and getting the vaccine, or do you have to go to a doctor's office and get it from your physician at that point?
Yeah, that's a great question. One I would love to give an answer to, but the short answer is we don't know at this point, right? This vaccine will enter the normal supply chain. Right now, the vaccines that currently exist, right? This is the Pfizer vaccine and soon the Moderna vaccine, require really cold storage. So there are only specific places where it can be administered. You have to have a facility that has the ability to store vaccines at that very low temperature. It's not just like a fridge. It has to be colder than that. And so you're going to see a lot of administration happening in facilities that have that ability. Some of the vaccines coming down the pike will, in theory, require less cold storage, where it's a little bit easier to get. It's more likely that you could get it in a setting other than a doctor's office or a hospital that has that deep, sort of the very cold storage facilities available. And so a lot of this is still in flux, right? Because we're still going to be getting new vaccines. They're going to have new characteristics around how you have to store them and when you get the dosage. So I love all the questions, but one thing I do want to avoid is sort of getting out over my skis on where I'm an expert. But I do just keep emphasizing, like, some of this is still really early, right? We just got approval of the Pfizer vaccine. We're just getting approval of the Moderna vaccine. And, I would love to tell you that there is a sort of detailed plan out there exactly how this is going to go. But right now, a lot of this is in recommendation form. And we're going to see how the rollout happens and how effective folks are at getting the vaccine out to people that need them in the States, and then how effective the states are at sort of taking things to that next step. So that was one group's analysis and sort of recommendations around the vaccine. This is ACIP, which is the committee that evaluates vaccines in the United States. They tend to make recommendations about who gets vaccines. Their recommendations carry some weight because it leads to no cost sharing in many public markets. And so they had a meeting. They presented some early recommendations around their goals and principles. These are, make decent amount of sense here, but maximizing the benefits, ensuring that there's equity in distribution, that specific groups aren't being left out, promoting transparency in the vaccine distribution process so folks know what's happening, and their allocation sort of in a phase 1 and sort of a 1A, 1B, 1C is pretty similar to what we just looked at, right? Sort of healthcare settings, healthcare workers getting it first, who are more likely to be directly exposed to COVID, individuals who live in facilities like we talked about, like nursing homes or assisted living. The second group is essential workers, right? So those are folks on the front lines, interacting with people, there's various estimates of how many folks are in that bucket, but sort of them at high risk of contracting COVID. And then phase 1C, you get to older and higher risk adults, individuals with high risk medical conditions. I think this is where patients with MS would fall. But you see a pattern, right? This is not exactly the same as what we just showed on the prior slide, but you can sort of see similar things, similar estimates on folks in the various groups, and then sort of the similar phase of trying to sort of vaccinate folks either at highest risk of catching it because of their jobs or the situations in which they live, and then from that moving on to adults with high risk conditions for contracting COVID. So that was a lot on the vaccine side of things here. So that is the end of the particular slides. I think we're ready, Kyle, to go into some questions.
We sure are. And Rebecca, I think you were going to handle the Q&A on your side, so I'm going to shut up now.
Yeah, absolutely. So once again, if you have a question for Chris or Kyle, you can absolutely put that in the chat box, and we will do our best to filter through those. But to start off, I know, Chris, you mentioned, again, we know that you're not an immunologist, and Kyle, you might be able to comment on this as well, but we've had a couple of questions come in about the clinical trials with the COVID vaccination, and specifically, there is concern from some of our clients that people with MS were not specifically included in any of the vaccine clinical trials. Can you comment on that?
Yeah, well, either me or Kyle can take it, but I think from my perspective, so I haven't seen specifically who is included or excluded, but I'll sort of take that as correct that folks were excluded. And frankly, they were trying to do this as fast as possible, right? And when you're running a trial of that speed, you're trying to get this out. But I think one thing to just focus on here too is that there are obviously benefits of two things. One, we will continue to get more information, right? We don't have to have everything right here today. We don't have to have all the data. It's a trial. We just got an approval under sort of a emergency use authorization from the FDA. It's not even an official approval, right? It's an EUA. So you've kind of got part one of, we're still really early. We're starting the vaccination, and we're going to continue to get more and more data as this rolls out that folks can use to feel, particularly physicians can use to sort of make informed decisions going forward. I think the other piece too is that there are just benefits generally, right? And the goal of this rollout, and we saw this on some of the prior slides, is to vaccinate a lot of people and to try and reduce spread of COVID-19 to a point where it is safer, even if you don't have the vaccine, right? Even if you're not in one of the early groups, or if you're I think the New York Times or Washington Post did a little thing that was like, type in your information and you'll figure out where in line you are. It was at a line of like 100 people, and I think I was like third from the bottom or something, which wasn't a great feeling. But obviously, even in that situation, as folks are vaccinated, who are not me, right, or are not other folks, who may on this presentation, who may be further down that list if they tried that that little application. There's still benefits as it starts to reduce community spread. It starts to reduce deaths as it's focused on folks, and just generally the goal of many of these is to try to vaccinate folks and get as many vaccinations out there such that the spread goes down, such that it is safer even if you're not vaccinated. So again, not an immunologist. I don't want to sort of pretend to be one. So I'm just going to keep saying that every 2 seconds. But I do think, it is natural to be looking for information and sort of be questioning right off the bat, but preaching a little bit of patience as more information comes in as this process rolls out. I think it's just an important thing to know that there's plenty of people paying attention to this going forward.
And I, on my side, I don't really have any updates personally. I'm not really clued into the research side either. But I do see that other MS organizations are going to be reviewing this information and issuing guidance. And I imagine we will be doing the same with our chief medical officer in the future. So, to be continued there. But thank you, Christine, my good friend, in the comments for that note.
So an advocacy question, back to the reason we are all here tonight. Could you talk about executive orders and how is it that they seem to be able to bypass the entire congressional process?
Yeah, that's a great question. So I think I'm sure a lot of people have seen Trump administration executive orders over the last really a lot in the last 6 months and thought, wow, they're doing a lot of things through executive orders. An executive order is basically a letter that the president signs and sends. It's public, but is effectively just a note to the agencies to say, do this thing, right? That's what an executive order is. It's not binding. You can rescind it. You can put it out. It is literally instructing regulatory agencies to do something. And so what an executive order really is just sort of a policy setting agenda or sort of a policy setting tool from a president to his agencies to say, I want you to do this thing. So one of the things that we got an executive order on at the end of July was a most favored nation drug pricing proposal in Medicare Part B. Trump administration said, or President Trump said, go do this. And then in November, CMMI released a demonstration doing that, right? So think of them as like precursors for regulatory action. The authority is still in regulation. The authority is still in regulatory entities like Department of Health and Human Services or others. But executive orders are a way for a president to sort of publicly announce, I intend to do this thing and I'm instructing my agencies to do this thing. And then it's through regulatory action, which in many cases is able to bypass congressional intent or congressional, gridlock in many of these cases.
And speaking of the gridlock in this current political environment, what is the likelihood that anything will actually get done in this current Congress?
I think it is, gosh, that's a good question. I think things will get done. I don't think they will be major developments, right? Particularly in healthcare. It's going to be tricky to come to bipartisan agreement. I think we'll probably get another COVID package or two coming through. I think that we may get Medicare Part D reform that I mentioned as sort of a bipartisan healthcare package. But aside from that, it's going to be pretty slim. I think, Kyle asked a good question earlier about bipartisan action, right? Is there a chance for bipartisan actions from Republicans, Democrats, and the Biden presidency? And there is a chance, but given the gridlock and given the politicalization of some of these issues, I am a little more on the pessimistic side that the material things are going to get done, particularly things that really help with coverage, right, or help with affordability. I think there's a limited chance of that moving forward.
And also moving forward, just one last question from the audience tonight. What are some things that you expect will happen within the first 30 days of the Biden-Harris administration?
Oh, that's a great question. I think, we'll get a lot of executive orders, I think is to the earlier question, sort of instructing agencies to go off and do things. It's going to be almost all COVID focused. Like, I think this is what you can imagine coming into the beginning of the Biden administration. It is going to be very COVID focused. I would expect to see more CDC guidance than we've seen for a while. I would expect to see more detailed plans for vaccine distribution. I would expect that you see the Biden administration really focus on putting people up for agencies that deal with COVID first and sort of Senate confirmations. Those are the kind of things I expect to see a lot of right off the bat. And frankly, beyond the first 30 days, right, that's going to be the first 3 months. That's going to be the first 6 months. And then some of these coverage issues, some of this Medicare stuff we talked about, other topics are going to start bubbling up. But you can tell from the people on the transition team, you can tell from the appointments being made, you can tell from the public statements, their goal is to solve COVID. Then they're going to turn to some other policy priorities.
Well, great, Chris. I think I can speak on behalf of everyone in that we can just ask you questions all night long, and there would be no end to any of the information that you can give us. But for tonight, that concludes our webinar. I would once again like to thank Chris Sloan from Avalere for his insights and what's ahead on the health policy horizon. And as mentioned, tonight's webinar will be archived on our website. And we also ask if you could just help us out and take a very brief survey that is coming up next, which will be of great help to us in our advocacy and education efforts. This really helps us direct where we take our programs. And with that, on behalf of MSAA and Chris and Kyle and myself, we thank you so much for joining us, and we hope that you have a fabulous evening.